enjoyed the talk on food allergy and allergy sensitivity. My goal today is to go over what are the therapeutic advances in Crohn's disease. What do we know at this point in managing Crohn's disease? What are the current knowledge, but also the challenges in Crohn's disease treatment? So we're going to talk first how important it is when we are meeting a patient with Crohn's disease, how important it is to really stratify what is the risk of this patient developing complication in the long term. And if this patient is at high risk, it's very important to use effective therapy early in the course of the disease. And the question is, with all the biologic available to us, what is the best first biologic or second biologic in our patients? And then the next question in terms of therapy, do we need to use combination therapy of a biologic with an immunomodulator, or when can we use monotherapy biologic? And finally, I'll touch a little bit upon therapeutic drug monitoring, why it's important to really achieve a good drug level early in the course of the treatment. And putting all this together, what are our targets when we treat a patient and how can we achieve these targets? So we know when we meet a patient with a flare that probably there has been endoscopic inflammation for a while before the symptoms appeared. And once there's a flare, we make a diagnosis of Crohn's disease. If we don't do anything, or if we use non-effective therapies, what's going to happen is the patient will have flares and remission, flares and remission. But it's important to realize that with every flare, there's structural damage that occurs. Strictures are going to form, fistulas are going to form, and abscess will form. So with every flare that we're not treating properly, and in between the flare, if there's active inflammation that's not symptomatic that we are not treating, we are actually allowing structural damage to happen in Crohn's disease. So the key message here is that we should not wait for the patient to develop strictures or fistula or abscess to use effective therapy. We actually should start these therapy early after the diagnosis of Crohn's disease. This is a short window of opportunity where we can control the disease properly and prevent complication. So the question is, who are the patients at high risk of having severe disease? And how can we effectively treat those patients before they develop severe disease? So what prognostic factor are we going to use? Clinically, we're going to look at the age. Obviously, somebody who's young with Crohn's disease has many years ahead where strictures and complication can develop. So we need to be more aggressive in this patient population. Patient with severe symptoms, high disease burden is really affecting their quality of life. They're not able to go to work, to school, they're in the bathroom all the time, they're losing weight. Patients with perianal disease and extraintestinal manifestation, these are patients that have a higher disease burden and we need to really take seriously from the start. Then we have the evaluation. How does it look on endoscopy? Do we have deep mucosal ulcers? Is this an extensive disease, small bowel disease? Do we already have stricture? What does imaging look like in terms of small bowel imaging, MRI, CT, enterography? How much small bowel damage do we have? And then look at the markers of inflammation, the CRP and the calprotectin. In the future, maybe we can also use a microbiome signature or genetics or gene expression to assess risk factor for progression. But for now, what we're looking at is clinical, what we see on endoscopy and imaging, and our markers of inflammation. So putting all this together, the AGA, the American Gastro Association, has put a risk stratification in Crohn's disease. What are the factors that predict disease progression? Diagnosis at a young age, before age 30, extensive disease, perianal disease, rectal disease. If you see rectal ulcers, this is a high risk for developing perianal fistula. So it's very important to treat this patient properly. Deep ulceration, previous surgery because of Crohn's, and of course, if we have already stricture or penetrating behavior, somebody who's had fistula and abscesses. So if your patient has any of these risk factors, it's important to start effective therapy early after the diagnosis of Crohn's disease. So the AGA put out a positioning therapy. Like I mentioned, we have multiple therapy. What should we choose for our patient? And anytime you're assessing the treatment option with a patient, it's important to really balance what are the risks of the disease itself if we don't treat it properly, what is the risk of complication, and what is the risk of treatment in this particular patient. For example, a patient with unstable heart failure, is at high risk of getting anti-TNF. That would be a poor choice. A patient with a history of malignancy, we have to put this into context if we're going to use, for example, thiopurine. These put the patient at higher risk of lymphoma, especially in the older population. So it's important to assess every time we're choosing a treatment, what is the risk of not treating the disease properly, and what is the risk of this treatment in this particular patient. And of course, it's important to discuss with the patient what are his preference or her preference in terms of lifestyle, logistic, injection, infusion, how quickly they want to feel better, do they travel a lot, really find the treatment that fits in their goals of care. If we have a patient with severe disease, high risk of disease progression, structural damage, high inflammatory burden, significant impact on quality of life, the AGA recommend as a first-line therapy anti-TNF, infliximab or adalimumab, and with combination therapy with thiopurine or methotrexate, and we'll talk about this, why this recommendation is there in a bit. If you have a patient with high inflammatory burden, disease that's very severe, extraintestinal manifestation like joint pain, ankylosing spondylitis, patients who are obese, we prefer infliximab over adalimumab because it's IV formulation. We can escalate the dose, we can adjust the dose to the weight, and we have a more effective and more rapid onset of action with infliximab. And also in patients with severe disease, we recommend combination therapy with immunomodulator over monotherapy. If the patient has contraindication to anti-TNF, then the first choice will be ustekinumab. Now, in case the anti-TNF failed, whether the patient developed anti-drug antibody or do not respond to anti-TNF, the next choice would be either a second anti-TNF. If the patient responded to the first anti-TNF and lost response because of antibodies and need anti-TNF, for example, perianal disease, patients with joint disease, we would use a second anti-TNF with an immunomodulator. If the patient is a primary non-responder to anti-TNF, if anti-TNF didn't do anything for them, if you use infliximab and despite good level, the patient did not respond, there's no point in using a second anti-TNF. We need to choose a different mechanism of action, and ustekinumab is a good option. Now, in patients who are at high risk of infection, who have a history of malignancy recently, who are older, who have multiple comorbidities, so safety is more of a concern. If they have moderate disease, we can start with vedolizumab, and if they don't respond, go to ustekinumab. If they have a higher disease burden, then vedolizumab might not be a good choice for them, and ustekinumab would be a first choice. And if they fail, then consider anti-TNF or vedolizumab. So I'd like to go over with you with some data on why we're having these recommendations, why we're positioning this therapy for more severe disease, anti-TNF, infliximab is favored, and for more moderate disease, maybe vedolizumab, etc. It's because the data that we have show that vedolizumab and ustekinumab actually work better with more moderate than severe Crohn's disease. So they work better if a patient has no prior history of bowel resection, has not been exposed to anti-TNF, there's no fistulizing disease, they have a good albumin level, so their nutrition status is good and their inflammatory burden is not high, and if their CRP is less than 10 milligram per liter. If the more of these factors you have, the higher is the probability that you will respond to vedolizumab in terms of steroid-free remission, deep remission, and mucosal healing. So the more of these factors you have, you add more points. This is your red bar that show a higher likelihood of response to vedolizumab. And I'm going to briefly go through that. This is a similar scenario with ustekinumab. The more we're having a patient that has good albumin, no active fistulizing disease, no prior bowel surgery, the higher likelihood they have to respond to ustekinumab. Now, we know from all the trials that if you have been on one anti-TNF first, your chances of responding to a second anti-TNF or to vedolizumab or ustekinumab decreases. Is the reverse true? If you start vedolizumab first, are you going to respond to anti-TNF as a second line as well if we use anti-TNF as a first line? And the answer is yes. So using vedolizumab as a first line, if your patient does not respond to vedolizumab and you choose to move to an anti-TNF, they're going to do as well as if they started anti-TNF in the first place. So treatment persistent, clinical response, clinical remission are the same for anti-TNF if it's used second line after vedolizumab or first line. So this is important when you're considering vedolizumab in the patient. You know that if it doesn't work, if you go to anti-TNF, the response will be as good as if you use anti-TNF in the first place. Now, it's important to discuss these head-to-head study. This is the CView study that was presented at DDW this year. This is the first head-to-head study in Crohn's disease, comparing the efficacy and the safety of adalimumab versus ustekinumab in patients with Crohn's disease that are biologic naive. So patients with Crohn's were randomized to ustekinumab versus adalimumab. And what we have here is that they're both as good as each other in achieving clinical remission and endoscopic remission. So adalimumab and ustekinumab, we don't have one that's superior to the other in terms of therapy, which is very reassuring. We're all very comfortable using adalimumab in Crohn's disease. So in a patient with contraindication to adalimumab, or if they prefer the convenience of the injection with ustekinumab every 8 weeks, you can safely use ustekinumab and know that you will get similar result as if you're using adalimumab. So clinical remission was similar and endoscopic remission was similar. And in terms of potential side effect, they both have a very similar safety profile. We did not see a difference in terms of serious side effect, including serious infection. So we have, strategized our treatment, what we're going to use first, what we're going to use next. Do we use combination therapy or not? So this whole idea came from the SONIC trial, if you remember, that looked at treatment-naive Crohn's disease patient and randomized them to either combination infliximab plus azathioprine or monotherapy infliximab or monotherapy azathioprine. And patient on combination therapy had a higher success rate than patient on monotherapy. They had a higher chances of achieving steroid-free clinical remission at week 26. But when we looked at a few years later at infliximab drug level, we see that actually patients on combination therapy have a higher infliximab drug level than patient on infliximab monotherapy. So could this drug level be the reason why combination therapy works better? And the answer is yes. If you look at different infliximab drug level at week 30, and you'll see that for the same drug level, whether you're on combination therapy, infliximab plus azathioprine, or infliximab alone, you will achieve a similar clinical success. So it's actually the combination therapy, what it's doing, the azathioprine is increasing the drug level of infliximab by decreasing infliximab clearance and preventing antibody formation. So the sense here is that the drug level with infliximab is more important, whether using monotherapy than combination in achieving clinical remission, as opposed to using combination therapy. So that brings me to what are the factors that affect anti-TNF clearance. And we talked about using thiopurine or methotrexate to boost the drug level and prevent antidrug antibody formation. If you have a patient with more severe illness, high TNF burden, low albumin, high CRP, these are patients that are going to lose anti-TNF in their stool. They're going to waste it in their stool. So it's important to follow the drug level and adjust the dose to reach the right drug level. Second, we have the problem of developing anti-drug antibody. We can use immunomodulator to prevent that. But the thing that we have learned in recent years is that the higher risk of developing anti-drug antibody to anti-TNF is in the first year of use. And there might be a genetic component to that, which is the HLA-DQA105. This is a gene that's present in up to 40% of Europeans, and it's associated with a higher risk of developing antibody to anti-TNF. If you have this gene and you use infliximab alone without an immunomodulator, your chances of not developing antibody are zero, meaning 100% of people probably will develop antibody to infliximab. So when you have this gene, it's important to add an immunomodulator to prevent antibody formation. But what this PAN study has also shown is that even if you don't have that gene and you don't use immunomodulator, you still have around 40% chance of developing anti-drug antibody. So in all cases, if you don't have the gene and you use infliximab with immunomodulator, your chances of remaining free of anti-drug antibody is 60%. So the conclusion here, if you have the gene, you absolutely have to use an immunomodulator with anti-TNF. But even if you don't have the gene, if you use an immunomodulator, you can prevent anti-drug antibody development. So in my practice, when I'm using infliximab, I use immunomodulator with it for at least 1 year. And then I check drug level. I make sure we don't have anti-drug antibody before I withdraw the immunomodulator. But this is important to consider when we're considering treatment, because adding an immunomodulator, a thiopurine, can increase the risk of infection in our patient, risk of lymphoma. We need closer monitoring. So this is something to consider when you're using infliximab. You have to use an immunomodulator, but you want to make sure that this patient is not at high risk of infection and lymphoma, and that patient is going to be compliant with drug monitoring. How about the newer biologic? Well, actually for the newer biologic, vedolizumab or ustekinumab, their drug level, their efficacy, and the durability of their response is not affected by adding an immunomodulator. So whether you use them on monotherapy or combination, you'll have the same result. So the good news with these newer mechanism of action is that we do not need to use immunomodulator if you're using vedolizumab or ustekinumab. So talking about drug concentration, we talked about how it's important in terms of like achieving remission, but this is a recent study that was published in the Lancet that show us that actually that the drug level early during induction is important, and it has effect long-term in terms of remission. If you have a low drug level of infliximab or low drug level of adalimumab, your risk of being in non-remission at the end of the year is almost 100%. So if after the induction dose, drug level of infliximab or adalimumab are low, your patient will not be in remission at the end of the year. However, if the drug level is high and appropriate at the end of induction, they have a 40%, 60% chance of being in remission. So that's very important that to start thinking about checking drug level after induction and optimize it in order for our patient to be in remission at the end of the year. What is the optimal drug level? For in this study, it was an infliximab of 7 and adalimumab of 12 at week 14. But we have other studies looking at different numbers. In my practice, I shoot for infliximab level above 10 to 15. In patients with perianal disease, I shoot for a drug level around 18 and 20. And for adalimumab, I shoot for a level of 10 to 12. And I don't abandon these drugs as non-response before I achieve these levels. So before you say adalimumab did not work with a drug level of 5, optimize your drug level at least till 10. And if despite that you don't have a response, then you can say this is a treatment failure and you can switch. So always optimize your drug level before switching therapy. So I'm gonna end my talk with the treat to target concept. So we know now that we need to start treating early when we diagnose the patient with Crohn's disease who is at risk of developing complication over time. We know how to position the treatment. We're going to monitor the drug level. What is our final goal? What is our target, and how are we going to manage the patient long-term? Our goal, like we said, is to avoid serious complication and avoid disability. So we have to assess specific targets, specific goals for our patient. This is the target we're going to reach at a specific time. And we're going to monitor our patient frequently to see if we're reaching these goals. And if we're not, we're going to adjust the therapy so that we can achieve these goals. And in all that, it's important to keep the patient, the specific patient in mind, the needs of the specific patient. You're going to manage a young patient differently than you're managing an older patient. You're going to manage somebody with perianal disease differently than someone with only luminal disease. So what are our goals? What are our therapeutic targets? So STRIDE put out our target goals for IBD. First is clinical response. Obviously, we want our patients to feel better, to stop the diarrhea, to stop the joint pain, to stop the bleeding, to stop the abdominal pain. But we're pushing further, right? We need to have normalization of the CRP and the fecal calprotectin. These are markers of the gut inflammation, and we want to achieve endoscopic healing. In addition, for children with Crohn's disease, we want to make sure they have a normal growth. And for all patients, we want to give them a good quality of life and prevent disability. So why is the goal beyond clinical remission? Why do we want biomarker remission, CRP and fecal calprotectin becoming normal or in the acceptable range? And why do we want endoscopic healing? Because we know that clinical symptoms alone are not reliable to tell us what's going on in the gut. In the SONIC trial, up to 40% of patients who were in clinical remission, so feeling well, actually had endoscopic activity. And we know that if we have endoscopic activity, the disease will progress over time. And this is a different study. They looked around 400 patients who are with Crohn's disease in clinical remission. And they looked at those who had a normal CRP versus those who had a high CRP. Again, the CRP reflecting subclinical inflammation in the gut. And those that had a normal CRP had a higher chance of remaining free from being in the hospital and free from needing resection of their bowel because of Crohn's. So that we know that if there's subclinical inflammation, the patient is going to need to be in the hospital, they're going to flare, they're going to need to be surgery. So can we reverse that? If in our treatment, we target normalization of CRP, can we prevent hospitalization and surgery? And this is what the CALM trial did. In the CALM trial, patients with Crohn's disease were induced with adalimumab and then randomized to two arms. One is the clinical management arm, meaning we only adjust treatment, escalate treatment if the patient has symptoms. And one arm is a tight control arm where we escalate treatment if the patient has symptoms or if the patient has no symptoms, but the CRP or the fecal calprotectin are elevated. Treatment was escalated from adalimumab maintenance every other week to adalimumab every week to adalimumab every week plus azathioprine. And so what happened there? Well, patients in the tight control group achieved mucosal healing and steroid-free remission at a higher incident, a higher percentage than patient in the clinical control group. So if we adjust treatment, not only to clinical symptom, but also to inflammatory marker, we can achieve better result. And these patients had fewer hospitalization, longer period of remission, and increased quality of life. There was a higher cost due to monitoring of the CRP and the fecal calprotectin, but overall, by preventing hospitalization, by preventing surgery, this is a more effective, cost-effective strategy. And this effect was not only seen at the end of 1 year, it was seen up to 3 years. Patients that were in endoscopic remission had a decreased risk of progression over the next 3 years. So it's important to monitor our Crohn's patient. The target we're trying to reach is a CRP that's normal, a fecal calprotectin below 250, and no deep ulcers in the colon. If you see small aphthous ulcer, that's okay, but we don't want deep ulcers. If you can achieve that, we can optimize the outcome of our patient in the short term and the long term. But I want to put a caution there. We have to be realistic. Not everybody is going to achieve deep remission. Even with tight control, only 37% of patients achieve deep remission. So it's important to aim for deep remission, but also be realistic and not change too many things just because we didn't achieve deep remission. So I'm going to stop here and summarize what we learned today is that one, it's important to assess the disease severity and the risk of disease progression for a patient. So not only how the patient is doing now, but if they have risk of disease progression, we know we need to use effective therapy early in the course of the disease before structural damage happens, before complication. And we need to choose the right therapy for the right patient, taking into account the risk and benefit of the therapy and the goals of care for this particular patient. Combination therapy is a must with anti-TNF, especially with infliximab, especially in the first year of using infliximab. If the patient has the HLA-DQ genetic type that increase the risk of antibody, they should probably be on immunomodulator with anti-TNF long-term, or we can consider non-anti-TNF type of drug. With Vedo and ustekinumab, we do not need to use combination therapy. Proactive drug monitoring should be done, not only on during maintenance. I showed you it should be done early during the induction, because by optimizing our drug level, we can affect the chances of remission at the end of the year. And we need to treat to target, meaning we need to monitor our patient clinically with biomarker and adjust treatment, even if they're in remission, if their biomarkers are elevated, so we can optimize their outcome in the short term and in the long term. I'm going to stop there and thank you for listening today. Thank you for having me, and congratulations again on an amazing course.